Damaged nerves in the upper limb present an important clinical challenge and are the common subjects for examination at both university and higher degree levels. I would like to share with you my own approach to the anatomy and clinical diagnosis. I believe that the brachial plexus is designed to supply as many muscles as possible with nerves that have as many roots as possible, and thus limiting to some extent the effect of nerve damage. This is only partially successful in that damage to the roots of the plexus can be devastating, as indeed can be lesions of some of the peripheral nerves, as I plan to demonstrate to you. Of course, some nerve damage is worse than others. Some is irretrievable and some can have an excellent prognosis. The worst that can happen to a nerve is neurotmesis, where there is a complete or partial division of the nerve. Less serious and with a better chance of recovery is axonotmesis, where the axon is interrupted but the sheath is still intact with the chance of regrowth of the axon within it. Even less worrying is neuropraxia, which can be summed up as a bruising. It is important to stress that there are major differences between lesions of the brachial plexus at root level compared with damage to the individual peripheral nerves, but at times there is considerable similarities. For purely physical reasons, the upper and lower roots of the brachial plexus are more likely to be traumatized, and they will each result in a relatively discrete condition, as we plan to show you. But this is not to say that extreme injury cannot disrupt all the roots together. The clinical picture seen in damage to the peripheral nerves depends on the number of roots that they contain and the muscles that they supply. So, for instance, damage to the long thoracic nerve gives a loss of a single muscle, whilst damage to the ulnar nerve gives a loss of most of the small muscles of the hand. We will look at these lesions in turn. This image shows a composite picture of the common lesions. The pink crosses illustrate the damage to the upper C5 and C6 and lower C8 and T1 roots of the brachial plexus. The black crosses show damage to the commonly damaged peripheral nerves. These lesions will be discussed in more detail. So we'll start with lesions of the two upper roots of the brachial plexus. Muscles that have root values of C5 and C6 are shown here in blue. When we look at the actions of these various muscles, a clinical picture emerges. So that with loss of the rhomboids, we'll get a loss of retraction of the scapula. With loss of supraspinatus, infraspinatus, deltoid, and teres minor, we'll get a loss of abduction and external rotation of the shoulder. And then with loss of biceps brachialis and coracobrachialis, together with supinator and brachioradialis, we'll get a loss of elbow flexion and supination, so that the muscles which will now dominate are latissimus dorsi, pronator teres, and the pectoral muscles. So the cause of an upper brachial plexus injury can often be a shoulder dystocia during a difficult birth, or in adults, a trauma such as falling from a motorbike. The result is Erb's palsy, where there's atrophy and limpness of the upper arm, internal rotation of the shoulder, pronation of the forearm, with no elbow flexion, and the palm faces backwards. This is called a waiter's tip deformity, or I rather like the secret smoker's posture. There's a sensory loss in C5 root. The C5 root supplies the upper and lower lateral cutaneous nerves of arm, respectively from the axillary and radial nerves. If C6 is involved, the lateral cutaneous nerve of the forearm is affected in the musculocutaneous nerve. You can see on the small image on the left that the arm is thin and there is loss of bulk of the deltoid muscle. At the lower end of the plexus, the roots C8 and T1 are liable to damage. This image shows the various muscles that are lost. Importantly, these roots supply the small muscles of the hand. Indeed, loss of these muscles will have a devastating effect on hand function. There is C8 and T1 fibers in both the median and the ulnar nerves. In the median, there'll be 2 lateral lumbricals and 3 thenar muscles lost, which will lead to a claw hand and a very weak thumb. In the ulnar nerve, supplying the 2 medial lumbricals, 7 interossei, 3 hypothenar muscles, and the adductor pollicis. And loss of these muscles will lead to a claw hand, a loss of adduction and abduction of the fingers, loss of adduction of the thumb, and loss of the ability of the little finger to oppose, so that movements will be dominated then by the long extensors acting on the metacarpophalangeal joints and the long flexors acting on the interphalangeal joints. The clinical picture that emerges is Klumpke's palsy, caused by a pull on the arm at a breech delivery, giving hyperabduction of the shoulder, or in an adult, an apical carcinoma of the lung. The muscle loss is all the small muscles of the hand, and the sensory loss is the C8 in the medial hand and T1 in the medial forearm. The result is a clawed hand, and this may be associated with damage to the sympathetic chain to give a Horner's syndrome, which is typified by a small pupil, mild ptosis, a flushed face, a dry face, and apparent enophthalmos. Now we turn to lesions of the peripheral nerves. The important ones are shown here. Note that the all-important musculocutaneous nerve is not very liable to damage, as it's so well protected within the anterior flexor arm muscles. The long thoracic nerve, the axillary nerve, the radial nerve, the median nerve, and the ulnar nerve are all at risk. Many of these peripheral nerve injuries are associated with fractures or dislocation of the humerus. So damage at the surgical neck of the humerus will often damage the axillary nerve as it passes around the neck of the humerus with the posterior circumflex humeral artery. Then in the mid-shaft area, the radial nerve is liable to damage as it passes in the spiral groove with the profunda brachii artery. Next, in a supracondylar fracture, the median nerve is liable to damage, and also the brachial artery can easily be damaged. And then trauma in the region of the medial epicondyle can damage the ulnar nerve as it passes behind the epicondyle with the ulnar collateral artery. Now, the long thoracic nerve is very liable to iatrogenic damage. And a dissection of the neck can be seen emerging from the roots C5, 6, and 7 and passing down on the lateral wall of the thoracic cage in the mid-axillary line to supply serratus anterior. Damage to the long thoracic nerve, C5, 6, 7, is caused during axillary surgery or sometimes during the insertion of a chest drain. and occasionally it is a congenital problem. The result is a loss of serratus anterior with its ability to protrude and rotate the scapula. This results in what we call a winged scapula. There is no sensory loss, but we can test the ability of the serratus anterior by asking the patient to press against the wall and see if the scapula protrudes posteriorly. Serratus anterior is an interesting muscle because it has 8 slips from the posteromedial aspect of the scapula to the first 8 ribs. It uses all 5, 6, and 7 roots to protrude the scapula, but it can selectively use C7 to the lower 4 slips to rotate the scapula. And as rotation of the scapula is an important adjunct to abduction of the shoulder, this movement is thus limited in this lesion. Next, we can look at the results of damage to the axillary nerve. It arises from the posterior cord and has the roots C5 and 6. This is despite the fact that looking at the brachial plexus, it could potentially have many more roots. This emphasizes an important point about the brachial plexus, that just because a nerve could have many roots, it does not necessarily have them. A further example of this is the musculocutaneous nerve that could have C7 in it, but I don't believe it has. The lower right image shows how the axillary nerve curls around the surgical neck of the humerus, and it's easy to understand how it could be damaged both in a fracture and also in about 5% of dislocations of the shoulder. There will be loss and wasting of the deltoid and teres minor, and the movement loss will be a poor flexion, extension, and the abduction of the shoulder. If there is a dislocation, you can see in the lower left image how this shoulder appears rather square. Clinically, this is an important image as it stresses the need to test for loss of sensation over what we call the regimental patch. This is the autonomous area of the upper lateral cutaneous nerve of arm. In order to exclude damage to the nerve during replacement of a dislocation, it's mandatory to test for sensation before manipulation is performed. Motor activity cannot be assessed adequately in the acute situation, as it would be too painful for the patient. Next, we look at the radial nerve and see that it could, and indeed does, have supply from all the posterior brachial plexus roots, C5, 6, 7, 8, and T1. Now first, let's have a look at some details of the radial nerve. It leaves the axilla via the lateral triangular space with the profunda brachii artery. It spirals or posteriorly around the humerus between the heads of triceps and only touches the bone in the lower groove. It then emerges anteriorly between brachialis and brachioradialis to lie just lateral to the cubital fossa. It supplies 3 cutaneous branches to the posterior cutaneous nerves of the arm and forearm and the lower lateral cutaneous nerve of arm. The muscular branches of the radial nerve itself are to triceps, brachioradialis, extensor carpi radialis longus, and anconeus, and often there's a small twig to brachialis. Then the extensors of the forearm by the posterior interosseous branch. The effect of damage varies somewhat according to the level of injury, which could be in the axilla, in the spiral groove, or in the forearm. But first let's look at the axilla. Now the radial nerve uniquely has branches which tend to leave the main nerve at a much more proximal level than they really need to. So, for instance, the supply to triceps leaves the radial nerve in the axilla. So in the axilla, there could be damage from surgical trauma, and the muscles that are inevitably lost are triceps and all the extensors of the wrist and fingers. There'll be sensory loss over the first dorsal web space, which is the autonomous area, and much of the lateral side of the dorsal surface of the hand and the 3.5 fingers. In the spiral groove, the nerve to extensor carpi radialis longus emerges from the main nerve at approximately at mid-humeral level. As this muscle is essential to avoid a wrist drop and may not be damaged in a humeral fracture, the appearance of wrist drop is variable in a radial nerve injury. The lower the fracture, the less likely there'll be a wrist drop. Again, damage is caused in the spiral groove by a fracture of the mid-shaft of the humerus, and we will lose the extensors of the wrist and finger. But note that it is the loss of extensor carpi radialis longus that determines whether or not there is a wrist drop. Damage to the branches of the radial nerve in the forearm are caused by trauma, surgical mishap, or fracture dislocation of the radial head. The muscle loss will be extensors of the wrist and fingers, but because extensor carpi radialis longus is spared, there will be no wrist drop. The clinical problem with a wrist drop is that it is impossible to grip satisfactorily. This can be helped with a simple forearm, what's known as a cock-up splint, which extends into the palm and extends it in such a way that it allows the fingers to flex more satisfactorily. Now let's look at the sensory loss associated with a radial nerve lesion. This also depends on the level of the injury. So, for instance, if the injury is in the axilla, there'll be a sensory loss in the hand, as shown here on this image, plus or minus the lower lateral cutaneous nerve of arm. In the spiral groove, the sensory loss will be again in the hand, as shown on this image, and the lower lateral cutaneous nerve of the arm is usually spared. In the forearm, there will only be sensory loss if there's damage to the superficial branch of the radial nerve. Note the autonomous area for testing on the dorsum of the hand is over the first dorsal interosseous muscle. We now turn to the median nerve. The good news is that it is rarely severely affected in a brachial plexus lesion, as it arises from so many roots. But conversely, the bad news is that a peripheral lesion of this nerve with so many roots will inevitably lead to severe loss of function, particularly in the forearm and hand. Now we need to know what muscles the median nerve supplies. So in the forearm, it supplies pronator teres, flexor carpi radialis, palmaris longus, flexor digitorum superficialis, and half, the lateral half, of the flexor digitorum profundus, and also the pronator quadratus. Then, as it passes into the hand, deep to the flexor retinaculum, the easiest way of remembering the muscles is the mnemonic LOAF, L-O-A-F. L for the two lateral lumbricals, O for opponens pollicis, A for abductor pollicis brevis, and F for flexor pollicis brevis. These last three are thenar muscles. And then there will be sensation supplied by the median nerve to the lateral 3.5 parts of the palm and digits. Note that there is a palmar cutaneous branch of the median nerve which emerges before the wrist and passes superficial to the carpal tunnel to supply the palm on the lateral side. So we can summarize the median nerve as having formed from two heads in the axilla, and it crosses to the medial side in the cubital fossa. It then passes between the two heads of pronator teres, and at the wrist it lies between the tendons of flexor carpi radialis and palmaris longus. And then it passes into the hand deep to the flexor retinaculum. In the forearm, it supplies flexor carpi radialis, palmaris longus, and then flexor digitorum superficialis. Then, via its anterior interosseous branch, it supplies flexor pollicis longus, the lateral half of flexor digitorum profundus, and pronator quadratus. It has branches in the hand, motor to the loaf muscles in the thenar eminence, as previously shown, and then the sensory fibers supply the palmar cutaneous branch, which we said leaves the median nerve above the wrist and runs superficial to the flexor retinaculum to supply the lateral palmar skin. And then the main nerve in the hand supplies the skin beyond the palmar skin, which includes the lateral 3.5 digits and the dorsal nail beds. A serious injury that is devastating for the median nerve is the supracondylar fracture. This fracture occurs just above the elbow joint, and the pull on the olecranon by triceps angles the broken lower end of the humerus anteriorly to impinge on the median nerve and the brachial artery. The muscle loss is all the anterior forearm muscles except flexor carpi ulnaris and the ulnar half of flexor digitorum profundus. We will lose the two radial lumbricals and the three thenar muscles. The adductor pollicis is spared because it's supplied by the ulnar nerve. If we look at the loss of movement, we see that there's a loss of pronation, there is weak wrist flexion and abduction. The thumb is virtually useless, with weak abduction and loss of opposition. The loss of flexor digitorum profundus to the index and middle fingers, and there is also a loss of flexor digitorum superficialis to all four fingers. So the result is that we get ulnar deviation of the wrist and thenar wasting. The sensory loss is the radial palm and the radial 3.5 fingers and nail beds. Although the nerve damage is important, the most urgent problem in the short term is damage and compression to the brachial artery. If the circulation to the forearm and hand is not restored rapidly and adequately, there is a severe late consequence, where the muscles are replaced by fibrous tissue and resulting in the classical appearance of Volkmann's ischemic contracture. The hand looks a little like a claw hand, but the wrist is flexed due to the more powerful long flexor muscles. There is extension of the metacarpophalangeal joints because of the insertion of the extensor muscles, and there is flexion of the interphalangeal joints due to the insertion of the long flexor muscles. So to summarize the clinical examination of a patient with supracondylar fracture, we will test for sensory loss over the lateral side of the hand, the palm and the lateral 3.5 fingers and nail beds. We'll look carefully at the autonomous area, which is the pulp of the index finger. Then we'll test for motor loss. We'll assess pronation of the forearm for the activities of pronator teres and pronator quadratus. We'll test wrist flexion to assess flexor carpi radialis. We'll test abduction of the thumb to assess the abductor pollicis brevis. We'll test opposition of the thumb to the little finger for opponens pollicis, and we'll test the flexion of the index finger for flexor digitorum profundus. A more distal injury to the median nerve is at wrist level. This is likely to occur with a wrist laceration or in the presence of a carpal tunnel syndrome. Examination will include looking for sensory loss on the lateral side of the palm and 3½ fingers, and also we'll assess the muscle loss for the LOAF as described previously in the thenar eminence. The forearm muscles, of course, will remain intact. So the result is thenar wasting and some clawing of the index and middle fingers due to the loss of the radial 2 lumbricals. Now let's have a look at testing for medial nerve damage. A loss of opponens pollicis leads to the inability to oppose the thumb to the index or little fingers. To test the loss of flexor digitorum superficialis, we use the test that is shown on the right. By stretching the tendons of flexor digitorum profundus and the intertendinous connections to the other 3 fingers, the tendon of flexor digitorum profundus to the middle finger is also effectively disabled. If flexor digitorum superficialis is intact, the proximal interphalangeal joint can be flexed, but there will be an inability to move the distal interphalangeal joint. This is the quadrigia phenomenon, which shows that flexor digitorum superficialis is working normally. In addition, we can look at the papal benediction sign. It's important to stress that we're actually asking the patient to make a fist, and the appearance is shown on the left. The ring and little fingers can flex perfectly well because of the presence of the medial side of flexor digitorum profundus, but on the index and middle finger there is the inability to flex because of absence of half profundus and flexor digitorum superficialis. In addition, there'll be wasting of the thenar eminence and some ulnar deviation. We can also see if the patient has the ability to lift the thumb away from the palm at right angles. We can simply request the patient to do this, or we can hold an object and ask them to touch it with their thumb. Now we'll take a look at the ulnar nerve damage. The ulnar nerve essentially has roots C8 and T1, and it is the T1 root that supplies the small muscles of the hand. We've already seen that there is T1 also in the median nerve for the 2 lumbricals and the muscles of the thenar eminence. Now the ulnar nerve passes from the brachial plexus posterior to the medial epicondyle of the humerus, and then between the 2 heads of flexor carpi ulnaris into the forearm. Then at the wrist, it lies lateral to the tendon of flexor carpi ulnaris, and then it enters the hand in the canal of Guillain, which lies superficial to the flexor retinaculum. Here it gives off a deep and a superficial branch. In the forearm, it supplies flexor carpi ulnaris and the medial half of flexor digitorum profundus. Just above the wrist, it gives the dorsal cutaneous branch to supply the medial skin of the dorsum of the hand and 1½ digits. Also, it gives a palmar cutaneous branch to the medial palmar skin. It then supplies in the hand on its superficial branch, palmaris brevis, and the skin of the palm are 1.5 digits. And the deep branch passes over the hook of the hamate and supplies 13 muscles, which will be shown to you in the next image. So we can summarize the muscles supplied by the ulnar nerve as the two muscles in the forearm, flexor carpi ulnaris, and the medial half of flexor digitorum profundus. Then in the hand, as 13 muscles. First, the hypothenar muscles to the little finger, opponens, abductor, and small flexor, and then to the medial 2 lumbricals, and then the 7 interossei, before ending in the adductor pollicis. The two most likely sites for injury of the ulnar nerve are either at the elbow or the wrist. Injuries at the elbow will disable all the muscles that are supplied by the nerve, leading to a clawed hand. The clawing happens to be less severe on the radial side as the two lateral lumbricals are intact, and they're supplied, of course, by the median nerve. We'll explain clawing in more detail later. The cause of damage at the elbow would be a fracture or dislocation of the elbow or direct damage to the medial epicondyle. The muscle loss is all the intrinsic muscles of the hand except the 2 radial lumbricals and the 3 thenar muscles, which are supplied by the median nerve. Also, we will lose flexor digitorum profundus to the ring and little fingers and the flexor carpi ulnaris. The result is clawing with loss of grip and loss of abduction and adduction of the fingers. The ulnar paradox dictates that there will be less clawing of the ring and little fingers with a lesion at the elbow than there would be with a lesion at the wrist. And we'll explain more about this later. There will be a sensory loss on the underside of the palm and the dorsal aspects of the hand and the ulnar 1.5 fingers. We will, of course, test the autonomous area for the ulnar nerve in the hand, which is the pulp of the little finger. An injury to the ulnar nerve at the wrist is similar to the one at the elbow, except that the 2 long flexors, half profundus and the flexor carpi ulnaris, are spared, and we'll see that the clawing is worse in this situation for the reasons we explained in the last image. Clinical testing of the ulnar nerve is essential. The palmar interossei adduct the fingers, and this activity can be assessed very easily, as shown here with a piece of paper between 2 of the fingers. Similarly, the dorsal interossei are tested by assessing their ability to splay the fingers under some resistance. Then there is a specific test for the ulnar nerve called Froment's test. Here we are assessing the adductor pollicis ability to hold a piece of paper between the base of the thumb and the metacarpophalangeal joint of the index finger. If the adductor pollicis is not functioning, then the patient uses the flexor pollicis longus to try to maintain the grip. This latter muscle is supplied by the median nerve and gives the patient the ability to cheat. Having mentioned clawing of the hand several times, we now need to explain it. It is somewhat complicated. First, we must understand the action of the interossei and lumbricals. The action of these 2 muscles is essentially the same, but with the interossei having the added ability to adduct and abduct the fingers. The important action that they have in common is shown here. They can flex the metacarpophalangeal joints while at the same time extending the interphalangeal joints. This is the essential movement of the hand for such action as writing or sewing and many other activities. As would be expected, if the muscles are not functioning, then the opposite occurs, as seen in the right-hand diagram below, where the metacarpophalangeal joints are extended and the interphalangeal joints are flexed. This is the typical appearance of a claw hand. Before we look at the more detailed analysis of clawing, we need to understand how the interossei and lumbricals achieve their actions on these joints. So the lumbricals arise from the tendons of flexor digitorum profundus and reach the fingers on their radial side, crossing the metacarpophalangeal joint on their palmar aspect at an angle that allows flexion of these joints. Their attachment to the extensor dorsal hoods also allows extension of the interphalangeal joints. The interossei arising from between the metacarpals are more in line with the metacarpophalangeal joints and thus cannot flex these joints without the addition of a second tendon to the base of the proximal phalanx. Their action on the dorsal hood is the same as the lumbricals. So to summarize on these rather larger images, we can see again that the lumbricals pass from the tendons of flexor digitorum profundus to the dorsal hood on the palmar side of the metacarpophalangeal joints, and therefore can achieve flexion of these joints at the same time as pulling on the dorsal hood and extending the interphalangeal joints, whereas the interossei are more in line with the metacarpals and therefore need two tendons to achieve the same effect. I feel that I need to justify my statement that the main function of the interossei is to flex and extend the finger joints and not cause adduction and abduction. So if we look at the left-hand image, number 1, it would be logical for the interossei tendons to attach at the center of the base of the proximal phalanx. However, in the middle image, number 2, if it did attach like this, it would be in the way of the long flexor tendons, and therefore instead, as in image number 3 on the right, it is attached to the side of the base of the proximal phalanx, and because these metacarpophalangeal joints are condyloid, the action is a mixture of flexion and either adduction or abduction, according to whether they are dorsal or palmar. Thus, the question to be answered is why, when there are both flexors and extensors of the fingers, do the extensors seem to win at the metacarpophalangeal joints in clawing? Now, this is explained here. In image 1, it's clear that the long flexor tendons have no direct action on these joints. They pass it on their way distally to flex the interphalangeal joints, but have no attachment to the bases of the proximal phalanges. In contrast, in image 2, the first attachment of the extensor dorsal hood is to the base of the proximal phalanx. Thus, in image 3, it is clear that the only two muscles that act directly to flex these metacarpophalangeal joints are the interossei and the lumbricals. Thus, to repeat, in image 3, it's clear that the only two muscles that act directly to flex these joints are the interossei and the lumbricals. If these two muscles are not functioning, then we can see in image 4 that the metacarpophalangeal joint will be extended by the attachment of the dorsal hood, which attaches to the base of the proximal phalanx. But the long flexor tendons are still able to flex the interphalangeal joints powerfully, and they overcome any attempts to extend these joints by the dorsal hood. This produces a clawed hand. Finally, and for completeness, irritation of the T1 root as it passes over the first rib, or more importantly, over a cervical rib, should be mentioned. The root may be irritated to the extent that the patient complains of paresthesia in the T1 sensory area on the medial side of the forearm, and this may be exaggerated when the shoulder is dropped.